Now we finish the business meeting, and I will invite you, for the lunch break. No. We have no. We have the arrhythmias with, yes. It means you will. Yes.
Hello, everyone. We can continue with the next session. It's so short but very important session about cardiac arrhythmia. And I would like to present the Professor Papagiannis. He will talk about post-operative arrhythmia in patients with congenital heart disease, diagnosis and management. Professor.
Hello, everybody. Welcome to Athens. I'm happy to meet with you all, and I'm glad you were able to come to this very nice gathering of colleagues from the Balkans. My presentation, and I would like to thank, of course, Dr. Kalangos for inviting me in this inaugural meeting of the Balkan Congenital Heart Disease Society. So my topic will be arrhythmias in patients with congenital heart disease, with a focus on postoperative atrial arrhythmias. And if we have time, I will say a few words on the management of ventricular arrhythmias. I guess we'll move this way. Arrhythmias in congenital heart disease are multifactorial. They are due to multiple factors, such as preoperative anatomy, which includes, I guess, I don't know if you cannot see the pointer. Okay. But you can see on the screen multiple factors such as anatomy of the sinus node in atrial isomerism or of the AV node with twin AV nodes, cyanosis, valve regurgitation and stenosis and coronary anomalies can predispose to arrhythmias. And then after the operation, the atriotomy incision can cause reentrant arrhythmias, sinus node damage to the AV node, ventricular tachycardias due to patches and incisions, and coronary artery anomalies. So all these factors contribute to development of arrhythmias in patients with congenital heart disease. The most common type of congenital heart disease, as we know, is an atrial septal defect, which, although considered a simple defect, can be, on the long term, can cause significant problems, and one of those is atrial arrhythmias. The most common type is atrial flutter, but we can have arrhythmias due to the atriotomy scar, and rarely arrhythmias due to the atrial septal patch. Patients with atrial septal defect develop arrhythmias progressively at a higher incidence depending on the age of surgery. So if a patient is operated before 11 years of age, the incidence of atrial tachycardias is only 4%, but progressively increases with the older age at repair and becomes very frequent if patients are operated on after 40 years of age. Another very important group of patients with atrial arrhythmias, as we know, is the patients who have undergone a Fontan procedure. And we know that the Fontan operation has undergone multiple transformations, starting from the old-style atriopulmonary Fontan, moving on to the intraatrial tunnel, and finally, nowadays, the extracardiac Fontan. These patients develop various arrhythmias, and the factors involved here include the sinus node dysfunction, atrial scar, the old-style Fontan, the number of prior cardiac surgeries, early postoperative arrhythmias, common AV valve, regurgitation, and higher preoperative pulmonary artery pressures. As we can see from this graph, the atriopulmonary Fontan almost universally is associated with atrial arrhythmias after long-term follow-up. At 30 years of age, almost 95% of patients have atrial tachycardias. In the other two most recent types of Fontan, the incidence of arrhythmias is about 25% long-term, with no significant difference between the intraatrial tunnel and the extracardiac tunnel. Various types of arrhythmias are seen after a Fontan, including the intraatrial reentry tachycardias, the automatic tachycardias, which can be either focal automatic or reentry focal tachycardias, AV node reentry tachycardia, and tachycardias related to the pre-existing accessory pathways, or sometimes, as I will show, to acquired accessory pathway, the twin AV node reentry, and finally, the final common pathway of all these arrhythmias can be atrial fibrillation. One must be particularly vigilant in order not to miss the diagnosis of atrial tachycardia in these patients, because sometimes you can be fooled by looking at the EKG and think that this is a sinus rhythm. As you can see on the left side of the screen, the P-wave morphology is not very different from sinus. However, the patient is constantly in this rhythm without variations. And as you can see on the right side of the screen, after conversion of the arrhythmia to sinus, the sinus node, the sinus rhythm is much slower than the atrial tachycardia rhythm. One must be aware that these patients usually have sinus node dysfunction, so to have a rhythm of 100 beats per minute constantly is not normal in a Fontan patient. Another group of patients with very high incidence of arrhythmias is the patients with transposition of the great arteries. And as we know, these patients, before they started being managed in a modern way with the arterial switch procedure in 1975, introduced by Dr. Jatin from Brazil, they were managed with atrial switch procedures, starting with a Senning operation and then the Mastard procedure. And many of these patients are still alive today, and they are older than 40 years of age, but they are also one of the most difficult groups of patients to deal with in terms of their arrhythmias and other morbidities. The anatomy of the Mastard operation is well known. As you can see, the superior vena cava and inferior vena cava are baffled to the left atrium, and the pulmonary veins to the right atrium. And this creates a very large volume of scar, and also with the high pressures, then the hypertrophy of the atria, the perfect substrate is created for development of arrhythmias. About 40% of these patients have intraatrial reentry tachycardias, and an equal number have sinus node dysfunction. Many patients require a pacemaker, and there is a high incidence of sudden cardiac death. The atrial tachycardia, which is the most common type of arrhythmia in these patients, is about 40%, with most of them being typical peritricuspid atrial flutter. But of course, to reach the area of the isthmus, you need to go to the pulmonary venous atrium most of the time. Other atrial arrhythmias, such as incisional atrial tachycardia, ectopic atrial tachycardia, and AV node reentry are also found in these patients. The development of arrhythmias is associated with worsening of the status of these patients, with development or worsening of congenital congestive heart failure, development of thromboembolic events, and the risk of sudden death. And also, the antiarrhythmic drugs that we use have a damaging effect, a worsening effect on the sinus node and AV nodal function, and may lead to need for a pacemaker implantation. So how do we evaluate patients with congenital heart disease and arrhythmias? The easiest test available to everybody is a 12-lead ECG, along with longer monitoring, such as Holter or looping event recorders, and nowadays with implantable loop recorders and data from pacemakers or ICDs. We also use cardiopulmonary exercise testing and a lot of imaging studies with echo, MRI, CT, and if necessary, cardiac catheterization. And finally, the electrophysiologic study, which provides us with a more detailed view of the underlying substrate. The therapeutic options in these patients include antiarrhythmic drugs, which have their problems, catheter ablation, which is the mainstay of therapy, and then, if necessary, surgical therapy for residual hemodynamic and arrhythmia problems, pacing, and ICD implantations. The rhythm control with medications is demonstrated in this table. First, we identify and treat precipitating factors and consider catheter ablation. But if we consider that the medications are appropriate, then we use this algorithm to decide which type of medications to use. If the patient has a simple or moderate type of congenital heart defect, then we look at the ventricular function. If the function is okay, then we can use almost every type of medication, starting with the simplest one like flecainide, propafenone, sotalol, and then moving on, if necessary, to amiodarone or dofetilide. If the patient has ventricular dysfunction, we skip the first category of drugs and go directly to the more advanced ones. If the patient has complex congenital heart disease, we use only amiodarone, dofetilide, or sotalol, and if there is ventricular dysfunction, we avoid sotalol. It's also important in these patients to not forget the need for anticoagulation, because the incidence of arrhythmias is associated with higher incidence of thromboembolism. If we are going to cardiovert the patient, then we need to look at the duration of the arrhythmia, and if necessary, start anticoagulation, otherwise go directly to cardioversion. However, on patients with moderate or severe congenital heart defect, then we need to look at the other factors and may need to give the old-style vitamin K antagonists or the newer NOAC medications, depending on their underlying function, complexity, and the CHADS-VASC score. If we are going to do a procedure like a catheter ablation, then we look at various factors. First of all, we look at the pattern of atrial tachycardia, the frequency of episodes and the symptoms, if the patient has been tried on medications, or if he has an underlying paced rhythm and a need for anti-tachycardia pacing, what is the ventricular function, what's the type of congenital heart defect, such as in Fontan patients who may need a transbaffle access, if there is a reversible problem, if the patient has comorbidities, and then we carefully review all the surgical records and imaging and the ECG tracings. And when we plan the procedure, we need to decide regarding the type of anesthesia that we're going to use, if it's going to be general anesthesia or conscious sedation, if we need hemodynamic support, as the patients may become very vulnerable during anesthesia and with long-standing tachycardia, the devices that we may need to reprogram, the need for imaging, such as transesophageal or intracardiac echo, look for vascular access problems, as these patients may have had multiple catheterizations and may have occluded femoral veins. We may need different access. We look at the anticoagulation, the need for antibiotics, and the type of catheters that we are going to use, with the need for multipolar electrode catheters, with irrigated catheters, 3D mapping systems, and various other tools. There have been several studies published on all these types of arrhythmias, and one of the largest studies that I found about the atriopulmonary Fontan procedure was published by Dr. Moore from the Los Angeles group. You can see here just you can get an idea about the multiple areas that can cause problems in Fontan patients with an atriopulmonary Fontan type. Most of these are located in the atrial, in the large subpulmonary atrial chamber, very few in the pulmonary venous chamber. These patients have many types of tachycardias, require very long procedures, sometimes up to 6 or 7 hours with long fluoro times and high fluoroscopy. And the new imaging systems have improved that significantly, but still there may need to be a need for radiation. The success rate was about 62% in this series, with partial success in 25 and failure in 13 patients. But unfortunately, long-term, oops, it's not moving. Yep. I don't know why we went blank. Okay. Unfortunately, the most significant problem here is the recurrence of arrhythmias, which happens in about 50% of patients. Complications are not infrequent, need for pacemaker, pericarditis, femoral vascular problems, and hemorrhage. And mortality may be an issue, although not usually related to the procedure, but to the underlying condition. It's not moving. I don't know how to. Okay. The same author published a series of ablations in extracardiac Fontan patients. And in this series, the most common type, again, was intraatrial reentry tachycardia, with second one being a focal tachycardia, but some patients had an accessory pathway to in AV node or AV node reentry tachycardia. It's not moving. One of the issues, as I mentioned, with the extracardiac tunnel Fontan is the need to go from the extracardiac tunnel to the intracardiac chambers. And there has been multiple approaches necessary to puncture the extracardiac conduit and go into the atrium. Many of these patients required, these patients require sometimes different approaches. I will show in the next slide. Okay. You can see here the extracardiac channel marked with ECC and the relationship with the right and left atrium. And then in this slide, you can see the various approaches that one can go to the intraatrial chambers, either puncturing directly the extracardiac tunnel or through native tissue, either from the pulmonary artery or from the inferior vena cava. These are technical issues that we face when we manage these problems. One of the more interesting approaches in this area is the magnetic navigation that is used by a limited number of people around the world. This requires very high technology with large magnets that can help to guide the catheter in almost every area in the heart, and requires the use of like MRI or CT cast, and on that we project the arrhythmia circuit, and then with the use of this magnetic navigation, the catheter can go to the specific area. And with this technology, you can avoid puncturing the extracardiac conduit and go directly retrograde from the aorta into the heart. Moving on to the atrial switch procedures, this slide demonstrates the anatomy of the either the mustard or the Senning operation. And as you can see from this slide, I wish I can demonstrate here on the screen. I cannot show it, sorry. But the isthmus between the tricuspid valve and the baffle is the most common substrate for the tachycardia, and we try to go to that area either puncturing the baffle or going retrograde from the aorta. We published about 25 years ago this series of patients with mustard or Senning who underwent the ablation of atrial tachycardia, and most common type was intraatrial reentry, with fewer patients having typical AV NRT or focal atrial tachycardia. As you can see also from this slide, the duration of the procedure was very long. 2 patients suffered AV block, but we had success in most of these patients, mostly using the retrograde approach, as you can see in this slide. But nowadays, we also try to go through the baffle. As we can see from this slide, this patient happened to have a transbaffle leak, and we were able to go directly to the pulmonary venous atrium and ablate his atrial tachycardia. There has been a study published on this topic comparing the 2 approaches, and they're about equal in terms of success, with a little higher rate of complications with the retrograde approach, mostly vascular or aortic valve complications. So I compiled the various series of catheter ablation for switch patients in this table and in this slide. As you can see from multiple series, the success rate is about 86%, with long-term recurrence in about 33% of the patients, and most of the patients had typical atrial flutter. More simple patients like tetralogy of Fallot also develop atrial flutter, as you can see from this slide. The typical isthmus ablation was managed with use of a 3D mapping system, and atrial flutter terminates during ablation here. Combining all the series that I was able to find from various substrates, the success rate was about 66 to 97%, but recurrence occurs in about 10 to 59%, and the chronic success rates vary between 53 and 92%, with worse outcomes in Fontan patients. Now, I will just show you a couple of examples of more unusual types of atrial arrhythmias in patients with Fontan. This was a patient that I managed when I was in the United States. This 25-year-old patient, in a very strange way, developed an acquired accessory pathway between the atrial appendage and the remnant of the right ventricle, and he had incessant tachycardias from this, and he was almost dying from this. So after failing multiple medications and other attempts of ablation, we went through the extracardiac conduit into the atrial appendage, and as you can see in the picture here, we managed to go to the base of the atrial appendage, and then the pre-excitation disappeared, as you can see on the right upper panel during ablation. You can see there was a small AP potential there, and then after multiple attempts, the accessory pathway was ablated, and then the patient developed a normal EKG and was free of arrhythmias on long-term follow-up. Patients with congenital heart disease can also develop typical AV node reentry tachycardia. We did a multi-center study of 109 patients with this and found that the most common group of patients who develop AVNRT were those who had right heart pressure or volume overload. When patients had complex congenital heart disease, as you can see in group A, the success rate was 82%, but when they have simpler type of congenital heart disease, it was 97%. Long-term success was 86% in the complex group and 100% in the simple group. But patients in the complex group had a higher incidence of AV damage and need for chronic pacing. And another unusual type of arrhythmia is caused by the presence of twin AV nodes. Patients who have atrial isomerism, especially of the right type, may have two AV nodes. And as you can see here, this patient has a common AV valve, and there is an AV node in the superior part of the valve and another AV node in the inferior part, and they join together at the ventricular level through a sling called the Monkeberg sling. There can be, under certain circumstances, a reentry between these two AV nodes, causing the so-called twin AV node tachycardia. We had a small series of these patients, and interestingly, all of them had a right atrial isomerism and common AV valve. Two were before a Fontan, one was after a Fontan, and we needed to go transbaffle to do the ablation. But we also found typical AV node reentry in addition to the twin AV node reentry tachycardia in all these three patients. We were able to go through the baffle to puncture the baffle and then go to the superior AV node and terminate the tachycardia there. So here I'm done with the atrial arrhythmias. I don't know if we have a few more minutes to go a little bit over the ventricular arrhythmias. I will not spend a long time on this because in the interest of time. We know that patients with congenital heart disease have a high incidence of sudden cardiac death. This study, about 30 years ago, by Mike Celiker, showed that the higher risk group were the patients with detransposition of the great arteries, after atrial switch procedures, and the patients with obstructive left heart lesions such as aortic stenosis and coarctation, and of course patients with tetralogy of Fallot. In another study, as you can see here from this pie chart, the higher incidence was found in patients with Eisenmenger syndrome, followed by correct transposition, tetralogy of Fallot, and left-sided obstructive lesions, and other smaller groups. Focusing a little bit on the tetralogy patients, as you can see with the old-style operation, which involved a very large transannular patch, this was causing severe pulmonary regurgitation, damage to the coronary vasculature of the right ventricle, and all of this created a large arrhythmic substrate. The more recent types with a smaller patch, with a smaller either transannular or only pulmonary valvotomy and transatrial transpulmonary repair cause very low incidence of arrhythmias. From this slide here, you can see the seminal finding by Dr. Gadzoulis that the length of the QRS more than 180 milliseconds was a risk factor for arrhythmias. And on the right side of the screen, you can see how the incidence of arrhythmias increases with age, becoming much higher after 25 years from the time of the operation. There have been multiple publications on the risk factors of ventricular arrhythmias. One of the first ones was this study by Paul Carey, showing that these factors, which include prior palliative shunt, inducible sustained ventricular tachycardia, QRS duration, ventriculotomy, evidence of non-sustained VT, and left ventricular diastolic pressure more than 12 millimeters, could create a risk score. And if the risk score was between 0 and 2, the incidence of appropriate shocks was 0. If the risk score was 3 to 5, it was an intermediate of 3.8, but if the risk score was more than 6, it was associated with a higher, much higher incidence of appropriate shocks. Other studies showed the importance of the various isthmuses that develop in the right ventricle between the ventriculotomy or the patch that is placed in the anterior right ventricular wall, and also the subpulmonary conus, and between the VSD patch and the tricuspid annulus. A more recent study just published this year showed the importance of these slowly conducting isthmuses in patients with tetralogy of Fallot. As you can see, if there is a slowly conducting isthmus, there is much higher incidence of sustained monomorphic VT. And then other factors play a role, such as age, history of atrial arrhythmias, history of sustained or non-sustained VT, and the prolongation of the QRS interval. There is an older study here showing the importance of surgery plus intraoperative ablation of arrhythmias that was able to reduce the incidence of VT from 21 to 9% after a combined operative repair of the substrate and the ablation of arrhythmias. In this final slide I have here, you can see an algorithm of the management of ventricular arrhythmia in a patient with congenital heart disease. So we first evaluate for residual or new anatomical abnormalities and see if there is any benefit of repairing them. And then if the patient has no significant abnormalities, then we go for ablation of the, we go for catheter ablation if there are significant underlying problems with moderate or severe congenital heart disease. We can either go for ablation, then an ICD, or if there is mild underlying problems, we can do ICD implantation. And if there are significant underlying problems, we can go for ICD implantation. And if there are significant arrhythmias afterwards, then we can do a catheter ablation afterwards. So I'd just like to conclude by saying that atrial and ventricular tachycardias are frequent after surgical correction of congenital heart disease and worsen the clinical picture and prognosis. Newer surgical techniques have significantly reduced the incidence of arrhythmias in patients with congenital heart disease. With interventional therapy, with catheter ablation, we can significantly reduce the burden of arrhythmias, the need for pharmacologic therapy, and need for devices, and improve the prognosis. Thank you very much for your attention. With this, I would like also to invite you to our upcoming meeting in Athens in September. It's called the Pediatric, and it's going to be done in September 10 to 12. I have brought some brochures outside. You can take one when you go out. Thank you very much.
Thank you, Professor. Professor Kalambos, I don't know, did you agree? Because other lecture is recorded. Yeah. Do you want to have a question now or after
the presentation of Professor Celiker, we can join the discussion.
Okay, Professor Papagiannis, thanks one more. Other presentation is recorded by Dr. Celiker from Turkey. The topic is device treatment for pediatric and congenital heart problems.
Mr. Chairman, ladies and gentlemen, my topic is the device treatments for pediatric and congenital heart problems. As you know, the pacing technology started in 1950s with a huge battery and then lots of electrodes to pace the hearts. Following the development of the newer technologies, especially after the 2000, we have much more use this kind of treatment methods in our patients. The indications for the device treatments, the bradycardia is the main methodology. Also, it can be used in tachycardia management, in the management of the cardiac synchronization, and also it can be used arrhythmia monitoring. System insists two main systems. One is the battery, which is protected by a titanium outer capsule, lithium power supply, electronic parts, and there are several sensors, microcomputer and software, and also the lead that conduct the impulse from the battery to pace the atriums or ventricles. In the treatment of the bradycardia, there are several methods. One of them is the transvenous method. It is traditional. There are single or two electrode types. Epicardial pacing systems, especially used in small kids and in some patients with heart surgery, previous heart surgery. Biventricular systems sense the stimulation to both ventricles to ensure the synchronization of the ventricles. And the recent development of the leadless pacemaker, in the system, the battery and electrodes are located in the same device. It is usually placed in the right ventricle through the femoral vein. So if you look again, in 1950s, the epicardial systems can be used, and after 1980s, the transvenous systems started to replace the epicardial pacing system, and around 2000, leadless pacemaker has been developed. Transvenous pacemaker, we need a lead that pass through the great veins towards the right atrium or right ventricle. In epicardial pacing systems, the electrode was implanted to the surface of the heart, epicardial area. The transvenous system can be single chamber or dual chamber. In single chamber pacing, it is not possible to ensure the AV synchrony. These are some slides. These children with transvenous pacing system in the right ventricle, and you can see the old of the epicardial pacing systems. This is a VDD pacing system. There is only single electrode. The right atrial dipole sends the atrial signal, and then ventricular electrode pace the ventricle. In the recent systems, we use the two electrodes. One is in the right atrium appendix, the other one is the right ventricle apex. There are several problems regarding the transvenous and epicardial pacemakers. It can be electrode complications such as pneumothorax or cardiac perforation, migration of the electrodes, venous occlusion, fracture, or insulation problems. And also, we can see the battery pocket and battery-related complications such as hematoma, skin erosion, infection, and cosmetic lesions. Leadless pacing recently innovated and mostly used in adult patients. It is less invasive, inserted through the femoral vein. There is no incision on the skin and no appearance of the pacemaker. And it's self-contained, equal to all pacemaker components such as battery, microcomputer, and electrodes. And it is almost more than 90% smaller than the conventional batteries. As you see here, there's femoral sheet, and then through this sheet, the leadless system can be implanted to the right ventricular apex. This is one of our patients. The lady has a transvenous pacing system, but the electrode is very old, so there is problem in the insulation. So we decided to put a leadless pacing system. As you see here, the leadless pacing system was implanted to the right ventricular apex. New indication for the cardiac devices is the cardiac resynchronization. What are the reasons? If there is a systemic ventricular dysynchronous, such as left bundle branch block, intraventricular conduction delay, or dysynchronous secondary to pacemaker treatments. If there is a grade 3 to 4 heart failure and low ejection fraction or increased QR respiration more than 135 milliseconds, then we can implant the cardiac device to synchronize the ventricle. The implantation can be done by transvenous or epicardial routes. It is necessary to determine the correct indication. Long-term consequences are not yet known. It is an effective method in the treatment of heart failure. It can eliminate the need for transplantation in some of patients if you pace the ventricle correctly and then correct the problem. So in transvenous system, there is one right atrial electrode, right ventricular electrode, and coronary sinus electrode. In epicardial system, right atrial, right ventricle, and left ventricular electrodes are implanted to the surface of the ventricle, to the epicardial area. This is one of our patients. This child has AV septal defect and operated for that. And following the surgery, she had AV block. And then a dual chamber pacing system was implanted. As you see here, the right atrial and right ventricular leads. But after a while, there is a left ventricular dilation with low ejection fraction. As you see in M-node echocardiography, the movement of the septum and free wall is abnormal. And then you can see the live 2D appearance of the echo. You can see the enlarged and diminished left ventricular function. Following implantation of the left ventricular leads, you can see the left ventricular diastolic dimension decreased from almost 6 centimeters to 3.5 centimeters. And the movement of the interventricular septum and left ventricular posterior wall looking normal. Then there are some innovations in the defibrillators. This image shows my first patient with non-compaction of the left ventricle. There is a relatively big device and then inserted through the subclavian vein and then to the right ventricular apex. And then what about the innovations? Creation of the better algorithm to detect the rhythm problems, optimization of the antitachycardic pacing and shock delivery functions. It can be used follow-up of heart failure, and it's possible to observe the problems from the home, and then development of the subcutaneous defibrillators. This is a intracardiac EGM finding. There is a fast rhythm converted by the shock, and then you can see the normal rhythm after the shock treatments. In subcutaneous ICDs, the battery was generated, was implanted to the subcutaneous area, and then so the lead is inserted through the subcutaneous space. In transvenous ICD, as in the normal pacing systems, pulse generated was implanted, was put in the prepectoral area, and the lead was implanted through the big venous system. What about the advantages and the disadvantages of the subcutaneous and transvenous ICDs? The advantage of the subcutaneous ICDs, there is no need for the vascular access. It is possible to implant without fluoroscopy, reduce midterm risk of lead malfunction, eliminate surgeon procedure risks such as pneumothorax tamponade, and improve arrhythmia discrimination, relative ease of extraction, hardware infection not associated with the endocarditis. But also transvenous ICDs has several advantages. Can have pacemaker and ATP functionality because there is no possible in the subcutaneous ICDs you cannot pace the ventricles or atrium. The pulse generator much more smaller, better battery longevity. The delivery can be shorter, and also we can able CRT optimization. No pre-implant ECG screening required, and then long-term follow-up data already available. First thing, life vests, which can be used in patients which are not suitable or not want to insert the ICD device. This device has 3 parts. One is the garment, which is worn under your normal clothing directly against the skin, includes an electrode belt, and then the electrode belt designed to detect the dangerous heart rhythms and deliver a treatment shock, and the monitorization system, which can be worn around the waist or with shoulder strap, and then continuously records heart rates. So especially this system maybe have not suitable for the subcutaneous or transvenous ICD system, or they don't want, if they don't accept an ICD system implanted for the treatment of the heart rhythm problem. In future, minimally invasive, in vivo compatible implantation can be possible. Wireless monitoring activating can be done by patient himself. Implantable device for post-op operation can be done, and then remote convenient signal can be read out. And then also non-invasive biomarker sensing can be done together with the pacing system. And during treatment of this in future, we can use the leadless pacing system much more than before. You can implant a single chamber ICD, leadless pacing, and then several leadless pacing systems together with the wireless monitoring, or single leadless pacing, dual pacing leadless pacing system, subcutaneous ICD with an implanted leadless pacing system can be done consequently to check the heart rhythm, to pace, and then to deliver the shock in the same patient group. So, ladies and gentlemen, in conclusion, cardiac device therapy has seen significant advancement in recent years. Apart from the treatment of bradycardia, which is its main area of use, it is increasingly used in the treatment of tachycardia and cardiac resynchronization. It is very promising that the device sizes will be noticeably reduced in coming years, especially with reduction of the battery. This aims to increase the experience of the new device treatment applied in adult patients as a result of their application in childhood and congenital cardiology. So, thank you so much. We would like to see some of you, if you are interested in the management of the cardiac rhythm. We will do SPEDA rhythm at September 2026 in Athens. Thank you so much.
Thank you. We have 10 minutes for comments or questions.
Yes, I enjoyed both lectures. And you covered the big part of the rhythmology, I believe, the pediatric rhythmology. I have, two questions. The first one, when you cannot puncture the extra cardiac conduit with your catheter, there is, some different approaches, hybrid approaches available, to do a small access surgically, and this one, especially, for surgeons, is very useful.
Yeah, I did not comment on that very much, but there have been publications of that, either with opening of the, like a small incision, or directly puncturing through the chest wall.
Oh, yes.
Under maybe echo guidance, go directly from the chest wall, which is a little bit more dangerous, I think.
Yes.
But with a hybrid approach.
Yes, because there is adhesions, and I believe there is the bleeding is not a major issue.
Yeah, because there is a lot of scar around there, which contains any bleeding, and so that's certainly a possibility. Yeah, when we cannot succeed with a transvenous approach.
Yes, and then the other question will be to Professor Celiker. Do you hear me?
Yes.
Yes, thank you very much. Greetings from Athens.
Yeah, greetings from Istanbul.
Yeah, very good. I will be soon. This one is really a very major contribution, the leadless pacemakers. I am wondering if is it possible to implant them in a single ventricle morphology? There was, such kind of attempts, especially in some Fontan cases.
Yes. Yeah, it's a good question. I think it's possible. The main problem is the thrombus formation through the or around the pacing system. Mm-hmm. If you can give some anticoagulation with new oral anticoagulation, it can be possible. Yes, it can be done, but the main problem, if it is personally, I put several years ago because of the pacing problems of the epicardial pacing system. Then our surgeon asked me to put a transvenous lead to the single ventricle patient, and then I give some anticoagulant, and it works well. But the main concern is the thrombus formation around the pacing system. Then it can be done, but it should need more work to do that.
And regarding the risk of migration or the risk of infection, there is some reports published in these two major issues.
Yeah, actually, it is also a good question, especially in patients with altered geometry of the ventricle. You should be very careful because these devices are made for the normal ventricles mostly. If you put the device in correct position, migration can happen. The slide that I shown there, at the following implantation, just 1 hour later, we see the increased threshold and some problems. But after a while, it's settled down and then turns to the normal level. So you should be very careful, especially with the altered geometry secondary to surgery. But it can be done. I think in the future, we will have more information about that.
Yeah. And in case of migration, is it possible, to hunt them and reposition them?
Yeah, I think there are some reports. It can be possible to extract with the use of big sheets, but you cannot use the same device again.
Yeah.
You have to implant another new one.
Yeah. Okay. Thank you very much.
Okay, thank you.
I would like to first say hi to my friend and colleague Alpai. I'm sorry you were not able to come in person.
Yeah.
But we are going to meet in September, and as Dr. Celiker said, we are organizing this meeting, and Alpai was the one who introduced the meeting 20 years ago, and he's one of the main organizers throughout the years, and we are working together on this meeting, so we are looking forward to it and invite all of you to come. Alpai, I wanted to ask you whether or not the leadless pacemaker is now a good choice for our young patients who may need infrequent pacing, such as, for example, patients with severe neurocardiogenic syncope, who may need pacing only very rarely, but it may be just what they need to have a backup pacemaker in their ventricle to pace them for a few seconds in order to avoid pulseless episodes. Given the fact that the leadless pacemakers now last a much longer time, would you consider that to be your first choice?
Yeah, maybe if it is the pacing system, it will be needed for the syncope or such as a asystolic syncope or something like that, or in very rare episodes of AV block, maybe in older kids such as maybe more than 40 kilogram or something like that, it can be implanted. Also, these devices has capability to do AV synchrony because they have sensors to detect the atrial impulse and then to pace the ventricle, but limited indication. But I think the most indication in older, older patients, such as after the adolescence, with the development of good AV synchrony capability, maybe we can offer this. But also, as you mentioned, if the patient has a little pacing support, maybe this patient will be a good candidate for this kind of pacing system.
Okay. Yes.
Yes, thank you. Thank you for these wonderful lectures. My name is Sergei Pric, and I'm from Belgrade. Cardiologists, we met each other, but through the internet connection, not in the live. It's very
You can
nice to
speak
see
a
you.
little bit louder because we
Okay. I have one question which is not related exactly with congenital heart diseases. It's actually from my clinical practice. A few years ago, I had a patient with atrial fibrillation and accessory pathway, but with the duration of complaints which were more than 2 days. What to do in that situation? Can we perform this shock or not? Because no medicines actually are helpful, especially amiodarone. You shouldn't give that medicine. And what to do in that situation?
I cannot hear very well. I'm sorry. Would you come up here?
It's situation with atrial fibrillation
Yes.
with accessory pathway and complaints more than 2 days.
During exercise testing, you say?
No. It's acute situation with
Acute.
atrial fibrillation
Right.
and accessory pathways.
Oh, yeah.
Yeah, and with duration of the complaints which were more than 2 days. Can we perform DC shock in that situation, or we should wait?
So patients who have high ventricular response with atrial fibrillation in an accessory pathway, that's the question. Yes. So how do we manage these patients? Okay, so first of all, you assess the hemodynamic status of the patient. If the patient is in shock, if the patient is hypotensive, then cardioversion is the first choice.
Regardless of the duration of complaints?
With consideration if the patient has been in long-term atrial fibrillation, then you need to know if it's been more than 48 hours, then you need to anticoagulate. But if the patient is in acute hemodynamic instability, then first of all, saving his life takes precedence. Now, if you have time to do a transesophageal echo or even just a transthoracic echo to look for a significant thrombus, it's better. If you don't have time, if the patient is in shock, then you cardiovert. If you have time, then you may do rate control, take your time to do a transesophageal echo, and if he's free of thrombus, either cardiovert him with medication or with cardioversion.
That means only rate control without any other antiarrhythmics?
Rate control without,
without amiodarone, without sotalol, right. without plecainidol.
If you have concerns about thrombus formation and you need to give anticoagulation, then you first do rate control for a while, like 2 or 3 weeks, until you achieve good anticoagulation, then you cardiovert.
Okay, thank you very much.
Can I say something?
Of course.
I think if there is a pre-excitation or Wolff-Parkinson-White syndrome, I think the best thing to do cardioversion when you see the first time. Yeah. Because sometimes it may provoke to ventricular fibrillation because of the pre-excitation. So at the first instance, when you see a patient with pre-excitation or Wolff-Parkinson-White syndrome with atrial fibrillation, I think the cardioversion will be the first option in this patient. But the other groups, as John said, then you have to look for, is there any thrombus formation or other things.
Okay.
Okay, thank you all. I think that we deserve the lunch.
Thank you very much.
Okay, buon appetito.